I really appreciate everybody taking the time to join. Our special guest speaker here today is Tamara Chandler, who's a Medicare specialist. It's been wonderful working with Tamara over the years. She's a jack of all trades. In addition to Medicare, she covers other type of health insurance as well. But this tends to be her baby. And so, hey, Tamara, good to see you. And so, yeah, so really excited to have her today. The way that we're going to do the presentation is tomorrow we'll have a slide up with my email. But if you have any questions, you can email me at Dave, D-A-V-E, for anyone that doesn't know how to spell Dave, at stablerwm.com. So again, Dave at stablerwm.com. And I believe I'll show up on the next slide. And then we'll have a couple of breaks throughout where I will kind of reiterate questions to Tamara and get those going. So that way folks can participate. Good. Yeah, so Tamara, looks like you're starting to share your screen. I see the Zoom screen. Yep, so get the presentation going there.
Okay. Make sure I'm sharing the right screen.
Yep, so I see the Medicare 101. So far, so
Great.
good.
Okay. And then I'm going to show your email address here one more time so folks can, they didn't catch it. Because if you have questions, this is the only way to ask questions during this presentation. So I want to make sure that you all have a way to do that. Oops, I'm just very sensitive, my little mouse today.
Yeah, perfect. Yeah, sounds good. So I'm on my email. So I'm ready and I'll send those back to you tomorrow.
Okay.
But yeah, we can go ahead and kick off. We got a great crowd here today, so let's get rolling.
So nice to speak with all of you today. Okay, so I think what we'll do is, I think we're doing Medicare 101. If you have specific questions or things that you're dealing with, send them to Dave, and there will be points along the way that we can answer questions. The people that I work with Medicare are those that are turning 65. They can be older than 65, but maybe their plan is changing or they're losing a plan. And they can be older than 65 and still working. I might be talking with them about how do you do that. And then finally, I work with people who are on Social Security disability and help them with their Medicare benefits. So let's get into what is Medicare. So there's a lot of misconceptions about what Medicare is. There's another word that's very similar to it called Medicaid. They are not the same thing. Medicare is a federal program. It's for US citizens and legal residents only, and it's individual health insurance. It's not Medicaid. That's for our low income folks. It's not Social Security itself for that we've all been paying into, and it's not a family plan. Next. All right, who can get Medicare? So anybody can sign up for Medicare if they are within 3 months of turning 65. It will begin on the first of the month in which you turn 65. Some people qualify for Medicare because they've been receiving Social Security disability income. After 24 months, they can get Medicare. Also, you can be streamlined into Medicare if you have end-stage renal disease and you're receiving dialysis, or you have ALS or Lou Gehrig's. Okay, so Medicare was invented back actually in the 40s, but it didn't come to fruition until the 1960s. And it was really just helpful to people who were paying cash for their medical care. And when it was designed, it was in two major components. The two components are Part A, as in Apple, hospital benefits, and Part B, medical insurance. And Part A helps you if you're actually admitted to a hospital. It's not going to do anything for you unless you're actually admitted to a hospital. And then it also covers skilled nursing facilities. It covers hospice, rehabilitation services, and then some drugs, but only while you're inpatient. That's A. And for most people, that section does not have a monthly premium. The only people that would have to pay for Part A are those that have not worked for at least 40 quarters or 10 years, or their spouse did not work. for that period of time. Part B, medical insurance. This is where most of us interact with the medical community. These are doctor visits and outpatient care. Mental health lives in this section. Durable medical equipment is here. There are a couple of very high dollar items that are in this section, and they are not limited to, but these are the ones I've experienced. They are when you're kept for observation. So you're sleeping in a hospital building, in a hospital bed, but you have not been admitted to the hospital. That's part B. Emergency room visits, part B. Chemotherapy, which is usually administered on an outpatient basis, part B. So it's a little bit misleading. Sometimes when I first learned about this, it felt like part B were things like I could handle on my own. And then I learned that was not true. All right, so I've touched on this a little bit. This Medicare Part A for most of us does not have a monthly premium. Medicare Part B has a monthly premium. This year it's set at $185. And next year, Kiplinger says it's going to be $206.50. There's an asterisk after that number because if your income was higher than $212,000 in 2024, then you will pay more for Part B. I'll show you a little bit about that. Okay, continuing on. So what happens when you go to the hospital? Well, if you actually get admitted, then Medicare says there's a deductible of $1,676 this year. It will be more next year. I don't know exactly how much it's going to be, but it will be more. And the way that it works is every time you're admitted to the hospital, you pay this $1,676, but it actually covers you from day 1 to day 60 days, which is, I don't know if you've ever looked at a hospital bill, but that's a bargain. The thing I don't like about it is that every time you get hospitalized, you get to pay it again. And I don't know if any of you have dealt with friends or family members who've been bouncing in and out of the hospital, but Medicare doesn't have a maximum out of pocket. So if you have to be going in and out of the hospital, there's no limit to how many times you would pay that. On the other side, if you're not admitted, then you have an annual deductible. So still what you're in the hospital, what would happen? It's under Part B. $257 this year. It'll be a little more next year. And then Medicare comes in and says they'll pay 80%. So I have a little story. It's time for story time. My mom and my sister lived together for many years. My sister's a nurse. My mom was exhibiting symptoms of a stroke, and which my sister recognized. And so she called me as she was leaving for the hospital saying, we're going to the emergency room. I think mom's having a stroke. And she said, all I can find in her wallet is this red, white, and blue card, the Medicare card. And so we thought that's all the insurance she had. And I Googled, because that's what I did, hospital benefits, Medicare. And at that time, the deductible for the hospital benefits was around $600. And so I said to my sister, no problem. Don't even worry about it. Just take her and I'll write you a check for $600 or for $300. If you could cover the other $3, that'd be great. And we've got it. So they got to the hospital, they administered blood thinners, and then they did an MRI and realized, she's having symptoms of a stroke, but it's not due to clotting. It's due to micro brain bleeds, and we just gave her blood thinners. So my mother did not die in that moment. She lived. She stayed in the hospital for 5 days, sleeping in a hospital bed in a hospital. So the whole time I'm thinking, oh yeah, no problem. It's the deductible. Everything was covered. About about a month later, we got a bill for $17,000 because she was never admitted to the hospital. And instead, she was kept for observation for 5 days while they did repeat MRIs and provided her with coagulating medicines so that her micro brain bleeds would stop. And what I didn't understand was that we were on the hook for 20% of that visit. And my mom could hear my sister and I fretting on the phone. And she came in and she said, well, I have this other card. And it turned, my mom's last job was working for the Forest Service, and federal employees have retirement benefits that pay for supplemental coverage for Medicare beneficiaries. So it turns out that thing came in and covered it all. We did not have to pay the $17,000. But I tell everybody this story because you don't get to choose. If you're being kept for observation, that is a decision that the provider makes, and the insurance follows suit. The medical insurance follows suit. So how we doing out there, Dave?
Yeah, I got some questions rolling in.
Okay.
Yeah, so that helps. And I guess first off, so Part A has no max out of pocket, but Part B does.
It does not. Neither
Okay.
one of them have maximum out of pocket. Hence the $17,000 bill that we received.
Okay.
Yeah, the
So
real
this
bill
is
was
where
like
the
18.
supplemental comes in and the Medicare Advantages that you'll hit on in a little bit later. Is
That's
that right?
right.
Okay. Okay, good. I got a question. So what if after age 65, you're able to stay on your spouse's health insurance for work? So let's say you're 67, your spouse is still working, they're a few years younger. Should you still
Yes.
apply for Medicare even though you're on your spouse's insurance?
Yes, this is a complicated answer. Sorry, I can't do this simply. So first,
Okay.
the first answer to the question is maybe you can do nothing. And the reason that you might be able to do nothing and you might want to do nothing is if you are contributing to a health savings account, you would definitely not want to sign up for Medicare, because even with a large group, so more than 20 employees, if your spouse's employer has more than 20 employees, you can choose to sign up for Medicare or not, either way, but Medicare would be secondary. But if you're contributing to an HSA account, you are not eligible anymore to make those contributions because you have secondary coverage. And that is true if you pick A only, and a lot of people do that because there's no monthly premium, or if you pick A and B. It makes it so that it's not truly a high deductible plan anymore. Therefore, you are not eligible to contribute.
Okay.
The most common thing I see is that people.
Yeah, go ahead. Yeah, go ahead and finish on your thought there.
Yeah, the most common thing I see is that people do choose Part A because they're not contributing to HSA, and then they wait for B because B has a cost associated with it.
Okay, so no HSA, it's a good rule of thumb. Typically, you may do Part A because why not? If
Yeah,
there's no cost. But if you're getting solid insurance, which is less expensive through your spouse's plan, you may not want to sign up for B because you got to pay for that one.
that's correct. I agree with that, everything you just said. And it is slightly more complicated than this because the Part D, which I haven't even talked about yet, the drug plan benefit, it has become much better than it ever was in the last couple of years. And so it becomes very important that the policy that you're on is considered credible. And this is a really important word, credible Part D coverage. Because if you decide to enroll in Medicare later in life and you didn't have credible coverage for D, you have a lifetime penalty to pay. There's also a penalty in B, but if you're with an employer with more than 20 employees, that by definition is credible coverage. So you're usually okay on B if you have the employer coverage.
Okay, gotcha. So I guess to sum it up, if your spouse is still working and you're on their plan, you don't have to sign up for Medicare. You get kind of a waiver on the penalty, but typically you sign up for Part A because there's no cost to it. Part D, though, however, can you wait until your spouse retires, or do you need to start that right at 65 if you want to be in Part D in the future to avoid the penalty?
Yeah. So the answer to that question is every year, the usually it's somebody who does what I do, but for group health insurance.
Mhm.
So your broker or your insurance company generates a letter that says this is credible coverage for Part D,
Mm.
hang on to that letter. In that becomes your golden ticket because if you do enroll in a Part D, let's say you do it when you're 70, then the insurance company, it's their responsibility to verify that you actually had credible coverage from 65 to 70, and they're going to ask you for proof. So that letter becomes your proof documentation.
Mm.
It's also, it can also, the employer can also provide this at that time. I just find that it's a scramble and very stressful. So the way you do it, if you can get ahead of that and just keep those letters, that will make your life easier.
Good. Yeah. So anyone who's furiously jotting down notes, we'll be sending out the recording of this, and also our office will take notes on these things and just add it to our playbook as well when we're having these conversations. But yeah, that's very helpful. One more question,
I
Tamara.
have a document. Yeah. And I have a
Oh,
document
good.
I can send you, Dave, and everyone else. This is from CMS. I didn't write it, but I like it that it's written by the Centers for Medicare and Medicaid Services. That's called Deciding Whether to Enroll in Medicare A and B when you turn 65. So it's really cool.
Yeah, I love that. We'll send that out to everybody.
Okay.
Good. And then one more plan before you continue on. Yeah, so you kind of mentioned with your mom, she had some additional insurance coverage through her employer.
Yeah.
We'll see this a lot with like PEB plans, I believe, if you
Right.
work for the state.
Right.
So how should people think about those? Is that something you should do on top of Medicare? Is it an either or? And I know each one's different, but just kind of high level, 30,000 foot.
Yeah.
How should we think about that?
So I would tell you that A and B are your foundation when you leave the employer or when you turn 65 if you've already left the employer. So forever you will have A and B. If you have access to an employer, whether it's because you work for the state or a school district or a large employer, if they offer retirement plans, you only get one chance. Go check them out because generally they're very heavily subsidized, meaning the premiums are low for what you get in the plan. Very, very important. Don't,
Mhm.
it's like leaving money on the table.
Mm. Okay. So don't ignore it.
Don't ignore it.
Yeah.
I mean, it might not fit your needs and maybe that's okay too, but yeah, you only get one chance.
Okay, good. I like it. Perfect. Good. Yeah, and one more just comment. I can't help myself on financial planning things that, come to mind. The health savings account. So Tamara, you mentioned you
Mm,
can't be contributing to a HSA health savings account while you're on Medicare. A lot of folks, so if you retire before 65 and you're on like a high deductible plan that qualifies, you
sure.
could keep contributing to those up until 65 or up until you start Medicare for that matter. And so
Yeah,
those are very cool. Of course, you want to make sure you get the right health insurance first and foremost, but where that fits in, that's something that we tend to be a big fan of and happy to chat with folks on that too. So,
right. And so some cool things for 2026, all bronze plans on the marketplace. You can contribute to an HSA. It no
mm,
longer has to be an HSA type plan. That's part of the most recent legislation from the.
very cool. Okay, good. Yeah, good stuff.
Yeah.
All right, good. Tomorrow, I'll let you keep rolling here.
Okay. So here's the icky part that Dave probably talks to you about your success. Here's the stuff that I want you to know about. If you're a married person and your income, this is all the 23 chart for 25, but the numbers are going to be very similar in 26. They just haven't been released yet. So I'm going to use these numbers. So for example, if I was talking to somebody who turned 65 in 2025, I would ask them, go check your tax return because you need to know now whether or not your income in 23 was more than 212. And the income that they're going to be looking at is adjusted gross, so line 11 from the 23 tax return, plus any contributions to retirement accounts. And if you're already receiving Social Security, that maybe some of that or all of it wasn't taxable, that gets added back into. And the icky part is if you're above 212 from, and I know it feels weird because it's like, well, we're talking about in 2025. Why are we talking about 23? It's because right now, the federal government is trying to figure out what everybody's going to pay in January. And none of us have filed our 25s because we're still in 25. So that is why they're looking that far back. They're looking at our, for 26, they'll be looking at our 24 tax returns. So this gets reconciled every year. And the dollar figures go up because the cost of living goes up and these numbers go up. So while I said originally Part B costs 185 or 206.50 next year is the estimate, these are the line items that you would actually pay if your income was greater than 212 or 106 if you're single filing taxes. So the icky part about this is that sometimes people sell a second home when they retire. And then a couple years later, all of a sudden their Medicare gets really expensive. Yeah, that's what's happening. I will say a little bit of good news here. If the reason that your income was higher 2 years ago was because of a job that you had at that time that you retired from, you can petition Social Security to reconsider that this is called IRMA, income related monthly adjustment amount, if the reason for the higher income was due to a job that you no longer have. So just file that away. So this is Part B, IRMA payments. All right. So Medicare Parts A and B do not cover a bunch of stuff. They don't cover prescription drugs that you pick up at a pharmacy. That's Part D, like dog, which was created in 2006. Medicare doesn't have an annual physical in the way that we think of it, where you go in and you get weighed and measured, and probably before you even have that appointment, maybe you go get some labs run. They don't have anything like that. You can still get some preventative care, but this program is so old, the concept of annual physical didn't exist. Also, original Medicare does not help you with getting your teeth cleaned or getting new eyeglasses or hearing aids. And it definitely doesn't cover long-term care. So if at any point in your life you are needing help, changing your clothes, bathing, eating, doing like the activities of just to get through a day, but not necessarily needing medical involvement, then Medicare says that's not us, that's somebody else. And that's another kind of insurance called long-term care. And that is not what we're talking about today. We're talking about medical insurance. All righty. Oh yes, this is one more. Now, what are your choices? So if you are with me on Medicare A and B being the foundation, I call it a house of cards because you know how you lean two cards up against each other? That's card A and card B. And then you get to fill in how the rest of the house works. One option is that you do something called a Medicare supplement or Medigap plan, which covers the things that Medicare doesn't cover and puts in place maximum out of pocket, which is something I'm very concerned about. And with that, you would pair it with a prescription drug plan, Part D. Both of these plans are administered by private insurance companies, and they're the stuff I sell. Alternatively, you can do something called Part C, which is also known as Medicare Advantage. You'll hear those words, they mean the same thing. And in Medicare Advantage, you still pay whatever Medicare tells you to pay for your IRMA and your Part B. But that money that you've sent in your whole life that pays for A and B, since Medicare is not going to pay the claims, they send that over to a private insurance company that covers you for hospitalization and outpatient care, and in most cases, prescription drugs as well. These Medicare Advantage plans are very attractive to people because they usually have extra benefits like dental, vision, hearing. Those are common in Medicare Advantage plans. And Medicare Advantage plans generally have lower premiums than Medigap plans. So it's not uncommon to see a Medicare Advantage plan with a 0 monthly premium, whereas Medigap plans start out at $59 and go up to $290. So over here, Medigap, 259 to 290 right now. Part D plans range from 0 to 110 in 2025. And Part C plans 0. I mean, there are plans that cost $300, but hardly anybody buys them. The most common plans have 0 premium, and you pay as you go. So the structure on Medicare Advantage is co-pays, co-insurance with a max out of pocket of $6,500 to $7,000. Structure on Medigap, if you buy the richest benefit structure, the costs are like I said, about $250 on a monthly basis. But when you go in on that plan, you pay one annual deductible, which is currently set at $257, and then you're done. Done. I don't care what else they need to do. You're done paying for services. And between Medicare and your Medigap plan, Plan G, you would pay nothing else except for the cost of prescriptions. Okay. So here's these are the supplemental plans. They are all designed by Medicare and sold and serviced by private insurance companies. So the richest benefit structure you can build for yourself is a Plan G. And those are the ones that I was saying in the 250 range is common for the Plan Gs in Washington state. Everybody pays the same in Washington, whether you're 65 or 95, they are the same price. And rates change throughout the year. Because every carrier is on its own schedule. What else do I want you to know? You can pick one of these lesser plans, like a K plan, which will run about $90 a month. It still puts in place a max out of pocket. In this case, this year it's $7,200, which is my big concern. I just don't want anybody to have the experience that we had, where we were on the hook for 20% with no limit, or at least we thought we were. And when I talk with people, we usually talk about how do you use medical care? How do you live your life? The cool thing about a med sup is that your primary insurance is Medicare care. So your network, for lack of, they don't really call it that, but for lack of a better word, is everybody in the United States and Puerto Rico that takes Medicare. That's who you could go to. And this comes in behind and looks at all of those gaps. So the 1676 that I told you about, it says, no, I got it. I will pay that in full, 100%. This one right here, 1676, Plan G says, paid in full. I don't care how many times you go to the hospital. I got it. So super cool coverage. But again, no dental, no vision, no hearing aid that is automatically built into the plan. One cool thing about the Medicare supplement plans these days is most offer gym memberships, which used to be a thing for Med Advantage and is now a thing for Med Subs too. So that's kind of fun. On the Med Advantage side of the fence, again, no monthly premium, but you do have copays when you see providers. And typically the drug plan benefit is built in. So the Part D plans are built in. And then they offer routine dental, routine eye exams. Some of them even offer restorative dental, no cost for hearing aid tests, and heavily discounted hearing aids. And then wellness programs, like I was saying, the Medicare Advantage plans usually, or were the first ones really to offer the gym memberships, which I think are super cool. How are we doing? Any questions?
Yep, I got a couple. Tamara, can you go back to that last chart if you don't mind?
Yeah.
With the supplemental.
Yeah.
Okay, so just for understanding, so Part A doesn't cost anything. Part B, it does. You have a premium that you pay, and there's no like out-of-pocket max for that, right? You're saying?
Correct. A and B do not have max out of pocket, so that is true.
And then you add the supplemental, which takes care of that. So how much more is adding the supplemental? So is it an increased premium versus just the B?
Yes. So in this case, like the richest benefit structure for most of the people in the room, there are still some that would qualify for these, but most people, G is the richest benefit structure you could build for yourself. And a G plan comes in and looks at everything except for one line item, which is Part B deductible, $257.
Hmm.
It'll be a little more next year. And says you are on the hook for that. But then it looks at everything else: hospital co-insurance, hospice, medical co-insurance, the 20% that we thought we were going to have to pay for our mom, um, blood, preventative care co-insurance. It comes in and it pays those things 100%. So on a G plan, like, and you do have to pay extra premium for this. This is not free. This is 238 to 290 is the
Okay. So
range.
kind of in that range. Yeah. So yeah, 230 to $300 more or less extra a month. But then you don't have to
Yeah.
worry about co-pays,
Mm-mm.
co-insurance, out of pocket.
All
That's just
gone.
sort of like an everything expense. Okay.
Right. And a lot of people call this the set it and forget it method because it goes up incrementally every year, but not significantly.
Hmm.
And then you just really don't have to worry. You could be anywhere in the United States if an emergency happened, or even if you live in two places. What That's very common. So you live in totally different states for parts of the year, and while you're away, you need to address, oh, it's time to get that knee replacement or whatever. Just do it wherever you are. Get it done. There you
Yeah.
go.
Okay. And then for Medicare Advantage, there's no premiums, which is nice, but you got to read the fine print just in terms of copays and whatnot. And
Mhm.
then you want to make sure, as it's not just universal Medicare, that that you have your doctors covered and whatnot by that.
Huge. That is
Um,
correct. So
okay.
I would say that if you're seriously looking at Med Advantage, the first thing you check is your existing provider community. There are PPO plans, meaning that you'd have like a national network of coverage. They're becoming less popular, less common. When they started, they were all HMO. So conceptually, like Kaiser Permanente. So you find a building that says Kaiser on it, you go in. And if you're in a state that doesn't have Kaiser, then you have emergency and urgent care only. So the example I usually give on an HMO product is I had a guy who was a client on a road trip in California, and he was on his motorcycle and there was an accident. And when they pulled the motorcycle off his leg, everybody was not confused. The ankle had been crushed. And so they went to the emergency room, covered, no problem. It was just like he was at home. But he made the next right decision because what they saw was he was so swollen that they couldn't do the surgery that day. And they wanted him to come back in 2 or 3 days when the swelling went down. And he made the right decision, which was, thank you very much. I will be having an air cast and as much pain medicine as appropriate, and I am going home, because it would not have been covered if he'd stayed in the California desert. The surgery would not have been covered on a Medicare Advantage HMO plan. So just a little warning on that.
Okay. On the Medicare Advantage, can you add, those different elements if you're doing travel or things like that, on top of it, or it's kind of here's what it
No.
is. Okay.
So
Gotcha.
every year you can change it. So if your lifestyle changes, there's open enrollment every year, just like there was at work and there is in the individual market. You can pick a different plan. The one caveat I will tell you is that if out of the gate you choose Med Advantage, that's fine. You can choose it. You can choose anything. However, if you keep a Medicare Advantage plan for more than 12 months, and you decide later in life, years go by, let's pretend years go by, and you decide, I really want to do Medicare supplement, then I would tell you, I hope your health is still very good, because the Medicare supplement companies are allowed to ask medical questions. And in Washington state, if you don't answer the questions in the way they want you to, they can say, no, thank you. We will not be working with you. So 12 months on a Med Advantage plan or less, you can go to Medicare Advantage, no questions asked. If you go beyond that, they get to ask questions. So there, in my world, that's called underwriting, and some people can make it through, and some people don't. I mean, I usually move somebody over to MedSup at least 2 or 3 times a year who makes it through underwriting, who just calls me up out of the blue and says, I don't have a rational reason for wanting to move to this. Like, nothing bad has happened, but I'm 72 or I'm 75 and I just feel like I should do Medicare supplement. And so we answer the questions and and they make it through. We usually I'll do a little bit of pre-underwriting with the person to find out, will you make it? Because I know what the questions are.
Likewise, can you move from Medicare Supplement to Medicare Advantage?
Every year there's open enrollment for Medicare Advantage. And if you make the change during open enrollment, there's no questions asked on the Med Advantage side of the fence.
Okay, okay, gotcha. So going to Medicare Advantage, there's no questions asked. You don't have to
Right.
qualify yep, okay. I got a question, and this is one we get a lot. Um, how does these two options cover you overseas for international travel? If, for a lot of folks, right, especially early in those retirement years, that's kind of an exciting thing to do. How should
Absolutely.
you cover yourself for that?
Yes. So it depends on the Medicare Advantage side. It is carrier specific. Um, Here's the things that are the same about the carriers that cover internationally. They only cover emergencies. They typically will not be recognized worldwide. Therefore, you will have to pay and get the bill and all of the discharge paperwork, and you will submit it for reimbursement when you get back, and they would adjudicate it or pay you back based on the way the plan is designed. So if it's a plan that has a $130 copay for emergency, then that would still be on you, but then they would reimburse you up to what the plan would pay in the US. There are some plans, some carriers that actually have worldwide recognition, so it does make it a little bit easier. So we would talk about those plans. On the Med Sup side of the fence, what you'll see here is I've got this little thing that says foreign travel emergency, again, only for emergencies. All the plans offer all the G plans. I'll be very specific. All the G plans offer $50,000 lifetime limit international or foreign travel emergency coverage, and the process is the same. You pay, you get reimbursed. Not my favorite. I am a huge fan of travel policies. I use them myself. They're relatively inexpensive. They generally have worldwide recognition. And they have other travel type benefits, not to get gross, but so what if you die abroad? Okay, how do you get the body back? Yeah, that kind of stuff. Travel policies.
Okay. Good. And then I guess if you're gonna roll the dice and go with the 50K lifetime limit, that should cover things fine. You'll get reimbursed up to 50K generally. That's typically not a
Yeah.
problem.
In most countries, the cost of care is so much less than it is here that the 80% line that you see here, it's not bothersome because they only pay up to 80% of what Medicare allows. But in most countries, that's enough, except for Singapore. Singapore is oddly expensive. Yeah.
Okay. Okay. So if you're doing a lot of international travel, it's probably a good idea to sit down with your insurance, contact and just kind of map out your plans and what you're looking to do. Because in a lot of cases, it's good to get something on top of, whatever's covered in these plans. Okay.
That's right. Yeah. Because Medicare itself does not help you at all worldwide. It is an only America thing.
Okay.
Medicare itself, yeah.
I see a few Boeing folks in here, and this has come up a lot. I know they have kind of a newer Aetna Medicare Advantage plan, and I know you probably don't know all the details on this. So far, like from our experience, we haven't heard a lot of horror stories. Like it seems like it's worked okay. And once you get off that, you can't get back on. Is the key to just make sure your doctor network's covered, or like what should you do if you're like, hey, I think I'm going to go for it? What's the homework assignment?
Yes. Check your doctors. It's kind of an amazing plan, and I can't speak because please talk to the team at Boeing. I can't say that enough. It's sort of an amazing Med Advantage plan because the rules are different for that plan. You can actually see people in and out of the network and have the coverage work the same way, which is amazing. But I would still check your prescriptions too, because every year the carriers can limit their covered drugs. They only have to cover two therapies. If two therapies are available for the disease state that you have, they only have to cover two of them. But that may not be the one that works for you. So I would still say check your doctors, check your drugs, and then get to know the plan. Yeah.
Okay.
It looks pretty neat. When I had to, because of the issues that Aetna had last year with UW, I got calls that I don't normally get, and I realized, oh, who cares if they can't come to an agreement? It's in and out of network. Yay. Yeah, it's a neat little plan.
Okay, good. Yeah, that's good to hear. Yes, if anyone's on it, yeah, I guess you don't have to run to your, phone after and get switched or
Yeah,
anything.
no. No.
Okay, good. Okay, very good. Yeah, that's great, Tamara. Keep going here.
All right. So we haven't really talked much about prescription drug coverage. So with a Medicare Advantage plan, generally the prescription drug coverage is a separate portion, but nevertheless included. And like I said, as we were talking about Aetna, it's very important to check your prescriptions with the prescription drug plan that you choose. And you would only do a prescription drug plan if you were doing Medicare supplement, because you don't really need to, because it would be built into your Med Advantage plan. I still say in both cases, there's going to be a list of covered drugs. Check to make sure they're covered the way you want them to be. And every year, I'm heading into it right now, starting October 15th through December 7th, you can change both your prescription drug plan and your Medicare Advantage plan, depending on which path you're on. Most plans do have a premium. As I was just looking at the plans for 2026, most plans do have a monthly premium. National average last year or this year was about 37. Looks like it's going up for next year. And they all have the same maximum out of pocket for the cost of drugs. 2026 max out of pocket is $2,100. And I don't care if that drug costs $17,000 a month. You pay $2,100. That's your worst case scenario. This is a huge change in Medicare. I think a good one. Yeah, this is not something you can, even if you don't take prescriptions. It's not uncommon for me to talk to somebody who doesn't take any prescriptions, and they say to me, "Well, I don't want to do a drug plan. I don't take prescriptions." I would tell them at least put in place a prescription plan that doesn't have a monthly premium or a very low premium, because just like staying on a work plan, if it's not credible coverage and you want it later in life, you will be penalized. And it's 1% of the average premium, 1% per month. So if you wait 5 years, that's 60 months that you didn't get insurance and you want it, and they're going to charge you 60% penalty forever. So zero premium, they exist, grab it, put it in place. And then if you did need a prescription, you'd also have that backbone there, which is useful. And if you don't, at least later in life, you're not penalized. What else do I want
Does this apply? I see at the end, it says you can get a Part D standalone or via Medicare Advantage. So those both qualify for that lock-in?
Either one is fine. They're both considered Part D credible coverage. Yeah, okay. So either way, yeah, it doesn't matter which path you choose. Just pick a path, put something in place. Don't ignore that section. And it is, this is the newest portion of Medicare. It didn't even exist until 2006. It's very recent. Oh, here's the other reason people don't want a drug plan. Success. Remember how on Part B there was a penalty called the IRMA? Well, there's an IRMA for D. It's much less painful. But again, same table here on the left side of the annual income, but it corresponds with the much lower IRMA, income-related monthly adjustment amount. And this is money that you'll pay directly to Medicare. You're not buying anything with this. Those who have pay more. That's what this is. So. We kind of already went over this. Yeah, so Medicare drug plans have 3 stages. There's a deductible phase, Current year is 590. Next year will be 615. Most plans do not apply the deductible for generics they like. You just pay the appropriate copay. The deductible usually applies for brand name drugs or generics that are more expensive that they don't like as much. And once you pay the deductible, then you pay 25% or 45%, depends on the drug, until you hit the max out of pocket. And again, max out of pocket this year was 2,000, next year 2,100. So not super scary numbers. I still think this is pretty cool. All right. So what plan should you choose? I don't know. You gotta work out what you want to do, how you live your life, what your resources are going to be in retirement. I don't think there's a bad choice. I would tell you that my experience has been whatever somebody picks, if they've done the homework, and I'm happy to help you do your homework, you pick the right one for you and you're happy. Much happier than, like, I do individual health. Nobody's happy. Medicare is way better, way better. It's really neat coverage. I'm waiting for the day I will get there. Yeah. There we go. What else should you consider? Yeah, I mean, these are the questions you ask yourself, and these are the questions I ask my customers when I'm talking with them. And also understanding, I mean, part of it is, I think, that the idea of Medicare supplement is really important to me, being able to have providers throughout the United States. I do a fair amount of travel within the United States. That becomes part of it. How you live your life, what drugs you take, and where you go to the doctor, that's how you make these decisions. I'm not going to say that some people don't make the decision on dental, because they do. So I actually had this conversation very recently with somebody who's new to Medicare who needs a bunch of dental work. Is like, oh, Med Advantage, they have dental plans. Yeah. How much? Well, there's this plan over here, has $3,000 to throw in your mouth. Okay, that sounds interesting. And they don't really have a lot of medical stuff going on. I don't know that that's a good way to make a decision, but it is a way to make a decision. I still think this is medical insurance, and you should be making your big decision based on how you interact with the medical community. And that's us. If you would like to reach out to the team at Stabler Wealth Management, this is the main email, team.
Yeah, team@stablerwm.com. And then, yeah, Tamara, is that the best way to contact you?
It is, yeah. So if you want to schedule an appointment with me, I have an autoresponder on that will go right back to you. So you can schedule an appointment and we can have a little personal Medicare one-on-one.
Yeah, that's great. Yeah, and feel free to contact us too. We could get you in touch with Tamara. I got a couple straggler questions. If we got it looks like we're gonna try to finish up at the end of the hour, so we could fit those in. I think I could answer the first one. So if I move from Medicare Advantage to supplement, can I move back to Medicare Advantage in the future? Sounds like yes. However, with the Boeing, because I know this is a Boeing person, I think once you're off Boeing, you can't get back on Boeing. So,
I would agree with all employer-sponsored retirement plans. That is everyone that I've come up against. Once you leave us, and usually there's a flashing red lights. Are you sure? Are you sure? Like a whole bunch of things that go off if you try to move someone off one of those plans.
Outside of that, though, you could go back and forth. I guess going to Medicare, back to Medicare supplement is when you have to take the test or pass the exam, basically.
That's exactly right. Yeah.
Okay. And then one HSA question, the health savings account. We had that example earlier where, let's say your working spouse is under 65. You're on their health insurance. If the retired spouse is over 65 and signs up for Medicare, can the younger spouse still do a HSA contribution since they're not on Medicare, just their spouses?
Yeah, absolutely. Yes.
Okay.
Yeah.
Per
so you just
person,
don't get
not
the
per
family.
Couple. Yeah.
Right. Yes.
Okay. You can't do the family though, because that was actually the nuance. So you could do the single or the individual.
Yes. Yeah.
Okay.
Because it's only one of you that has the secondary coverage, so the other one doesn't. So they're still fine.
Yeah, and I guess if the age 65 above didn't go on Medicare, sounds like a lot of times you probably want to, though, then theoretically you could do the family even though they're over 65. Okay, good. Yeah, well, this is great, Tamara. I really appreciate it. So this was Medicare presentation. We've got a lot of feedback, and we work with a lot of folks that are trying to get to Medicare, right? So that's
Yes.
the
In
individual
between.
insurance Tamara
Yeah.
mentioned. And so we're going to look to do a similar webinar probably early next year. Right now, there's a lot of conversation in terms of whether the the subsidy credits are set to go away next
Oh,
year at
sure.
over
Okay.
a certain income level. We don't need to hit on that today, but I know that's been coming up a little bit more. For example, with the government, shut down today and some of the arguments. So we'll see. As of now, we should probably know more in the next couple months definitively what that looks like. But we'll do a similar webinar plan next year where we'll go over pre-65, retirement insurance. So the
Love
individual
it.
coverage that Tamara mentioned. So
So I feel like I need to say something though. The
go
tax
for it.
credits
Do it.
are
Yeah.
not going there's no scenario where all the tax credits go away because the Affordable Care Act actually has that codified.
Yeah.
They
It's a
can't make it
sliding
all go.
scale though,
It's
right? Like I think it's kind
the
of a cliff.
cliff.
Is that right?
Yeah.
Yeah.
So we're returning to the cliff, which is 400% of the federal poverty level, which is still, if you live in King County, really hard to live on. So certainly some people will lose their tax credits unless Congress can do some magic here. But I would say that most of the people I work with will not be losing all of their tax credits. Yeah.
Yep. Okay. Yep. Sounds good. So we'll watch that closely and we'll have more definitive updates for that next one. But yeah, again, really appreciate y'all joining. If there's other topics you're interested in, let us know. Yep. These are fun to do and it's just another way to reach y'all. So yeah, thank you so much for your time. Thank you, Tamara. And yeah, we'll connect with y'all soon. So take care.